Hello, and thank you for joining me today for this introductory lecture into kidney physiology. I'm John Tsai from the Long Beach VA Medical Center and the UC Irvine School of Medicine. I'll be first talking about normal kidney physiology in the first several videos, and then go into abnormal kidney physiology. As you can imagine, we can give hours-long lectures on all of these topics, so this will be a very high-level overview and hopefully review some of the major physiological effects of the kidney that are important to the management of kidney disease. In this video, we'll be primarily focusing on normal kidney physiology. Let's dive right into normal kidney physiology. We have two kidneys, and the two renal arteries branch off the aorta around where the superior mesenteric artery takes off. The kidneys take up to about 20% of cardiac output, which is astonishingly high for the size of the organ, and it's an acknowledgement to the importance of the kidney to the homeostasis of the human body. The kidneys filter up to 150 liters of blood per day, of which it reabsorbs the majority of the water and electrolytes, ultimately resulting in a urine output of only 1 to 3 liters per day. The kidney is separated into two major areas, the medulla and the cortex. The cortex is the outer portion of the kidney that houses the glomeruli, the filter aspect of the kidney, while the medulla is home to both the loops of Henle and the medullary concentration gradient, an important aspect of water reabsorption and water homeostasis. We'll be discussing more about these in the coming slides. When we dive deeper into the individual nephrons in the kidney, we can see that the blood enters the glomerulus from the afferent arteriole and exits through the efferent arteriole. In the glomerulus, a fraction of the plasma is filtered and enters the Bowman space, where it forms the beginning of urine. The glomerulus is freely permeable to water, but impermeable to large substances such as proteins and cells. However, any damage to the glomerulus can result in these larger substances being found abnormally in the urine. Throughout the tubule, the process of reabsorption of important nutrients and water, as well as secretion of additional toxins and unwanted material occurs. Finally, the renal vein delivers clean, filtered blood back to the rest of the body, while urine is excreted through the ureters, which ultimately leads to the bladder and out through the urethra. It is important to remember that more than 99% of the filtrate is reabsorbed and returned back to the blood. You can imagine that if we're any less than that, we would become dehydrated and lose a lot of electrolytes very quickly due to the high amount of blood that is being filtered daily. One would think that this process is rather inefficient and counterintuitive. Why would we get rid of everything and then reabsorb everything back later on and through this complex process? If we have a system that actually keeps everything in the body but gets rid of things through active processes, you can imagine that if we ingest a toxin that we have never seen, our body would have no way of getting rid of that toxin if we haven't developed any processes to get rid of it. Additionally, it would be very difficult to assess how much urine that we would need to create in order to get rid of excess electrolytes. So biology has figured out that our current system of filtering everything and reabsorbing only what we need is probably the most efficient way our kidneys have of handling toxins, water, and electrolytes. In the kidneys, there are both passive and active transport mechanisms that ultimately help balance electrolytes, get rid of toxins, and reabsorb excess water. Firstly, we have diffusion across a concentration gradient that is responsible for the majority of processes in the kidney, especially reabsorption of water. We have simple diffusion that occurs across the cellular membrane, but also carrier-mediated and channel-mediated processes that help to facilitate that diffusion down a concentration gradient. Conversely, active transport, seen here on the left, normally works against a concentration gradient and would require energy use in the form of ATP, as seen on the pump-mediated side, or paired with a molecule down a concentration gradient, as seen in secondary or carrier-mediated transportation. The potential energy gained from the molecule going down the concentration gradient is paired with another molecule going against the concentration gradient. There are many types of transporters throughout the different areas of the kidney that are responsible for reabsorbing water and various molecules, but all work cohesively to maintain equilibrium and water homeostasis in the body. Here we can see the different areas of the kidney and where active and passive transport occurs in the kidney. 80% of the reabsorption of nutrients and electrolytes takes place in the proximal convoluted tubule through active and passive processes. especially sodium chloride and potassium. Bicarbonate is also avidly reabsorbed in the proximal tubule as well and plays an important role in maintaining our acid-base balance, as we will see later on. As we get further down into the kidney, the remainder of the tubule is responsible for fine-tuning electrolytes and creating the necessary milieu to optimize water reabsorption later in the collecting duct within the medulla. Let's take a closer look at water handling and see how antidiuretic hormone is important to water homeostasis in the body. Antidiuretic hormone is the major hormone that is responsible for water reabsorption in the body. But before we get to how it works in the kidney, let's first discuss what triggers for ADH and its actions are in the rest of the body. The hypothalamus is responsible for detecting volume-depleted states, which are typically accompanied by hyperosmolarity and low arterial blood volume. The low blood volume also increases sympathetic stimulation and the renin-angiotensin system to produce angiotensin II. All of these eventually lead to the production of ADH, antidiuretic hormone, or vasopressin, which is the same thing, from the posterior pituitary gland, where it has activity in two locations. First, ADH activity on the V1 receptors leads to vasoconstriction that leads to an increased vascular resistance and increased blood pressure. Second, antidiuretic hormone activity on the kidney in V2 receptors is responsible for the antidiuretic activity or water reabsorption activity that also results in an increase in blood volume and increase in arterial pressure. In your clinicals, you will actually see both of these in action. In the ICU, we typically use a substance called vasopressin, which is a synthetic analog of antidiuretic hormone that we produce in our body to produce a vasoconstrictive response and bring up blood pressure in patients whose blood pressures are low. Additionally, we treat diabetes insipidus with DDAVP, which is another synthetic analog of antidiuretic hormone. This induces water reabsorption in our body and brings down our sodium levels. While the two are derived from the same hormone, they vary slightly to specifically target effects on the V1 and V2 receptors in our body to produce their intended effects. Let's delve even further to where ADH acts in the kidney. Here we are at the level of the collecting duct, and on the right you see the V2 receptor, where ADH or AVP is active. Once ADH attaches to the V2 receptor, the resulting molecular cascade stimulates translocation of aquaporin II channels to the luminal or urine side. The aquaporin channel allows water to be reabsorbed back into the cells and then further back into the body to prevent diuresis, hence the name antidiuretic hormone. However, without a concentration gradient deriving the flow of water, ADH would not result in as much free water reabsorption as we would want. Let's take a look at how we develop this medullary concentration gradient that helps build the osmotic gradient to reabsorb water in our kidneys. So let's talk about why the medullary concentration gradient is important and how it's created. The medullary concentration gradient is essentially created by active transportation of sodium chloride and other molecules, specifically in areas 5 and 6 in this diagram, which represent the ascending limb of the loop of Henle. The sodium is more avidly reabsorbed in the deeper areas of the medulla, resulting in a higher concentration of sodium in the interstitial space deeper down into the kidneys, which form a gradient in the medulla. While water is being absorbed throughout the tubule, it is not until the late stages of the kidney in the collecting ducts, areas 7, 8, and 9 in the figure, that water reabsorption is fine-tuned to the point of no return. Hence, it is important that we have the highest concentration at the last stages deep in the kidney to reabsorb as much water as possible if we need it. Remember from the previous slide that ADH is only active in the collecting duct. So ADH opens the gate for the water to enter, but the medullary concentration gradient is really what drives the water out of the lumen into the extravascular space and later to be reabsorbed into the body. Now let's talk about how the kidneys maintain an optimal milieu for our cellular processes to continue. Specifically, we'll talk about sodium, potassium, and acid-base balance in our body. Our kidneys are responsible for managing other electrolytes, but due to time, we'll not cover these in today's talk. Serum sodium levels are represented by a concentration. This concentration is essentially the amount of sodium molecules divided by the amount of water in our body. In normal states, our serum sodium levels are usually around 140 milliequivalents per liter, but can range anywhere between about 135 to 145. When something goes wrong, this can be reflected in higher or lower serum sodium concentrations, and if it's in the lower direction, we term this hyponatremia, and if it's in the high direction, we term this hypernatremia. Severe hyponatremia is typically when we have serum sodium concentrations less than 120. As we have seen from the previous slides, there are mechanisms that the body uses to determine how much sodium and water is in the body. In most cases of an abnormal serum sodium level, it is usually abnormalities in the amount of water in our body that drives the serum sodium concentration up or down, and recall that the hormone responsible for water balance is antidiuretic hormone, or ADH. Remember from this slide that antidiuretic hormone is produced in response to several stimuli, most notably hyperosmolarity and a decrease in blood volume. ADH activates receptors in the kidney that result in fluid reabsorption, ultimately leading to an increase in blood volume. Because ADH is important at water handling in our body, any abnormality in this pathway can ultimately result in an abnormal serum sodium level. In the setting where we have too much water in our body, the ADH production cuts off and we no longer have the hormonal drive to reabsorb water. This results in our body getting rid of any excess water that we don't need as urine. Most water excretion is paired with sodium secretion, and we can see how this works with diuretics on the next slide. Here we can see the action of several different diuretics, but let's primarily focus on loop diuretics, thiazide diuretics, and aldosterone antagonists that have their actions in areas 3, 4, and 5 in this figure. These medications will block the sodium molecule reabsorption and result in what we call distal sodium delivery. The distal sodium delivery is usually paired with more water excretion, since a higher sodium concentration in the tubule will decrease the drive for water to move out of the tubule in the distal collecting duct in response to the medullary concentration gradient. The result is these diuretics cause not only excretion of sodium, but also an excretion of water from the body, hence the term diuretic. If you can remember the phrase, "where salt goes, water follows," then you can remember how diuretics work to remove excess water by blocking salt reabsorption. Now what about potassium, another very important electrolyte that is managed closely by our kidneys? Most of the potassium that is found in our body is actually intracellular, and very little is extracellular. However, any fluctuations from this narrow range that supports life can lead to devastating consequences, especially on cardiac cells. In the figure, you can see the EKG changes that occur with high potassium levels. With potassium levels of 7, you will start to see peak T waves, and as the potassium levels get higher, you can get a widened QRS complex, which ultimately can result in arrhythmia and death if left untreated. In fact, potassium chloride injected intravenously is typically one of the medications given for lethal injection after sedation with a barbiturate. Let's see more in depth at how the kidneys ensure that our potassium levels remain in a very narrow range. While most of the potassium is reabsorbed in the proximal tubule, the fine-tuning of potassium really occurs in the cortical collecting duct. Here, the major hormone responsible is aldosterone. We can see in this figure that a high potassium load through diet or otherwise will result in a higher aldosterone secretion. The aldosterone then increases translocation of the epithelial sodium channel, or ENaC, that results in higher reabsorption of sodium from the tubules. To maintain electrolyte neutrality, a potassium molecule must be excreted back into the lumen for every sodium molecule reabsorbed into the cell, which results in excretion of excess potassium from our body. When we have low potassium stores or take a low potassium diet over time, aldosterone is not secreted and hence potassium is retained in our body. We can see here that the potassium excretion relies on two major factors. One, the production of aldosterone, and two, the distal delivery of sodium. If one or both of these processes are affected, the ability to excrete potassium becomes impaired, and we will continue to discuss this in another video. Let's lastly talk about how the kidney manages our acid-base status. Acid production occurs as a byproduct of metabolic activity, and excess acid needs to be removed from the body somehow. As you may have already learned in your pulmonary lectures, the lungs have an incredible capacity to excrete carbon dioxide, which is one method the body gets rid of what are called volatile acids, or acids that can be evaporated by distillation. Unfortunately, non-volatile acids, the acids that cannot be evaporated, must be eliminated through the kidneys, or else the pH in our body quickly drops and metabolic processes that rely on a constant pH to maintain operation cease. Acid handling works hand in hand with bicarbonate handling in the kidneys, bicarbonate and carbonic acid being the major buffering system in our body. The acidic waste products produce protons, which are then combined with a bicarbonate anion, and through the action of an enzyme called carbonic anhydrase, this gets converted into carbon dioxide and water. The carbon dioxide is then excreted efficiently by the lungs. As you can see, when we lose quite a lot of bicarbonate through this process, and the kidneys are responsible for recovering and generating the bicarbonate that is used in the buffering process. There are three different processes in the kidney that allows our body to ensure that acid-base balance is achieved. First, recall that the serum is freely filtered through the glomerulus, so all the bicarb that is contained in the serum is also filtered into the urine. Over 80% of that bicarbonate is then reabsorbed in the proximal tubule, while the remaining of the bicarbonate being reabsorbed in the latter parts of the nephron. In the proximal tubule, another buffer called ammonia is produced, which is responsible for allowing the last process to occur, which is the secretion of protons in the distal tubule. We'll go over how this happens more in depth in the next few slides. Let's take a look first at the bicarbonate reabsorption process in the proximal tubule. The bicarbonate is first converted into carbon dioxide and water by the carbonic anhydrase enzyme on the luminal membrane. The carbon dioxide and water are then able to freely cross the membrane and enter the cells, where the conversion process is reversed by another carbonic anhydrase enzyme, resulting in a proton and a bicarbonate anion. The bicarbonate anion then gets reabsorbed into the blood through translocation with a sodium molecule with a sodium bicarbonate exchanger NBC1 transporter. The proton is then recycled back into the lumen of the urine via the sodium hydrogen exchanger, or NHE3. The enzymatic processes that are incredibly efficient and are able to efficiently recapture the majority of the bicarbonate that is excreted in the urine. So we can see here that the kidney is important to ensure no bicarbonate loss, which can affect our body's buffering system and subsequently our ability to maintain a normal pH. When we get into the distal tubule, the majority of the bicarbonate is already reabsorbed. But here, the process of acid secretion occurs. Let's take a look at how this works. Here we see our friends, the aldosterone-mediated sodium epithelial channel, or ENaC, paired with the renal outer medullary potassium channel, or ROMK channel. Again, that we saw a couple of slides ago when we were talking about potassium handling. However, the process goes further, so that when a potassium molecule is excreted, there's a transporter called the hydrogen potassium ATPase that exchanges a potassium molecule for a proton. Additionally, there's also the H+ ATPase, which also allows for ATP-dependent proton secretion in the distal tubule. As you can see here, these are the two major ways that our kidney secretes protons in the distal tubule. One is an aldosterone-mediated process, and the other is the H+ ATPase that does not depend upon aldosterone-mediated secretion of potassium. Lastly, let's take a look at ammonia generation and how this also helps regulate our acid-base status in our body. In the proximal tubule, glutamine is broken down into ammonia and bicarbonate. The ammonia is then secreted into the urine, where it can then act as a buffer in the distal tubule, which we will see on the next slide. The bicarbonate that is generated is translocated back into the plasma through the sodium bicarbonate exchanger, or NBC1 exchanger, that we saw a couple of slides ago. So let's see what happens to the ammonia. The ammonia in the form of NH3 that is secreted from the proximal tubule is then attached to a proton secreted by the distal cortical collecting duct that ultimately acts as a buffer to prevent the pH of the urine from getting too low. The ammonia buffers are necessary to prevent the pH of our urine from dropping below about 5, which is close to the lowest pH that our bladder can handle before acidic burns will destroy our urinary tract system. We covered a lot of ground today, but hopefully you will have a better appreciation of how the kidneys work to maintain our water and electrolyte balance. We went quickly through normal kidney physiology, how urine is made through the filtration, secretion, and excretion process. We also talked about how water is handled in the kidney through the action of ADH, or antidiuretic hormone. We then discussed how serum sodium concentrations are usually reflective of the water status in our body, and hence the importance of ADH in maintaining adequate sodium balance. We then talked about potassium control through the hormone aldosterone, and then lastly we talked about the different areas of the kidney that are responsible for acid-base homeostasis. I'll leave you with a question that will hopefully help to solidify your knowledge of renal physiology. Spironolactone is a medication that blocks aldosterone in the distal tubule. Which of the following effects are expected from the use of spironolactone? I'll give you a couple minutes to think about this, and then when you're ready for the answer, you can click Next to go to the answer. Spironolactone is expected to cause high potassium and may cause acidosis in our body. Let's see how that works with this diagram. So remember that potassium is secreted in aldosterone-dependent manner through the epithelial sodium channel, or ENaC. If we block the action of aldosterone, we no longer have ENaC activity, which decreases our ability to also excrete potassium through the ROMK channel. This is the buildup of potassium that may result in hyperkalemia in patients that are treated with spironolactone. Additionally, if we are not able to excrete potassium molecules, then this also limits our ability to excrete protons through the H plus K plus ATPase, which then results in buildup of acid in our body, otherwise known as acidosis. Now, in reality, hyperkalemia is a frequent complication of spironolactone use, but acidosis not quite as much, since we have other methods such as the H plus ATPase that we can use to excrete excess protons from our body. While spironolactone may cause a decrease in sodium reabsorption through the ENaC channel, the paired excretion of water usually balances out the sodium loss, so we usually do not see a change in sodium levels. And in fact, this is a medication used primarily as a diuretic to reduce any excess fluid in our body. While this is a tough question, hopefully this integrates a lot of what we learned about the kidney. We'll see you in our next video, and thank you very much for your attention.